I am Aubrey Schley, and Ethan Nowell is also here with us, and we're going to be talking about utilizing POCUS in acute kidney injury. So first off, what is an AKI? According to KDIGO guidelines, it's an abrupt decrease in kidney function that results in one of the three, an increase in the serum creatinine by 0.3 mg per liter within 48 hours, or an increase in the serum creatinine that's 1.5 times the baseline within 7 days, or a urine volume of less than 0.5 mL per kg per hour for 6 hours. There's some other guidelines as to different stagings of AKIs. So stage 1, the serum creatinine can be 1.5 to 1.9 times the baseline or greater than equal to 0.3 mg per deciliter with a urine output of less than 0.5 mL per kg per hour for 6 to 12 hours. Stage 2 can be 2 to 2.9 times the baseline or urine output less than 0.5 mL per kg per hour for greater than or equal to 12 hours. In stage 3, AKI would be a serum creatinine of 3 times the baseline, increase in serum creatinine to greater than or equal to 4, or initiation of renal replacement therapy. Or in our pediatric patients less than 18 years old, it would be a decrease in the GFR to less than 35 mL per minute, or a urine output of less than 0.3 mL per kg per hour for greater than or equal to 24 hours, or anuria for greater than or equal to 12 hours. So why is it important to detect, monitor, and diagnose an AKI? It's very prevalent. The overall incidence is about 20% of hospitalized patients, and then in ICU patients, the incidence is about 50%. AKIs are associated with an increased morbidity and mortality, no matter the reason for admission. And the AKI stage correlates with the risk of mortality. And AKIs are sometimes potentially reversible if the cause can be identified and treated appropriately. There are multiple different types of AKIs and a large number of things that can cause each of these types, but they are broadly divided into 3 different categories. Pre-renal, which is usually from decreased perfusion of the kidneys. Intrinsic, which is an insult to that can progress to damage of the kidney tubules or direct damage to the actual nephron. And post-renal AKIs are from obstruction of urinary flow. Briefly talking about renal ultrasound technique and how we would look at the kidneys. Usually we would use a curvilinear transducer and then set it in the abdominal preset. You'd want to look at it in 2 different views, the longitudinal view and the transverse view. To see the kidney in the longitudinal view, you would point the probe indicator cephalic towards the patient's head, and then place your probe at the mid axillary line around the 10th or 11th intercostal space. And sometimes you have to rotate the transducer to go along the edge of the rib spaces in order to optimize the view. And then you can rock the probe to center the kidney on the ultrasound screen and then fan the probe in order to assess the entire kidney. In order to obtain the transverse view, once the kidney is centered on the longitudinal view, you'll turn the probe 90 degrees so that the probe indicator is facing posteriorly on the patient. And then you'll also fan the probe in order to assess the entire kidney in this transverse view. Some renal ultrasound normal findings that we should typically see starting from the outside and working our way in. You can see the renal cortex. You can see the medullary pyramids, which are noted here as hypoechoic, the renal sinuses, the minor and major calyxes, and then the renal pelvis. And then on the right, you can see it without the labels. And this is the kidney in the transverse view, where you can see the renal cortex, medullary pyramid, the renal pelvis. Some renal findings that you can see in CKD, generally you can see decreased length, decreased cortical thickness, and you can see increased echogenicity. So here are some examples of that. For image A on the far left, you can see hyperechoic cortex, and you compare that to the liver. In this example, the cortex has a normal thickness and the length is normal for size. In image B in the center, you can see a hyperechoic renal cortex and a thin parenchyma with both the cortex and the medulla that's less than 1 centimeter. And in image C, you can see increased differentiation of the medulla and the cortex.
All right. So now we'll talk about the ultrasound findings that you would see in different types of AKI. So we'll start, and for the framework for this, we'll use those same broad categories, starting with pre-renal AKIs. So in this situation, your examination of the kidney itself will generally be normal. You'll have normal appearance of the cortex, normal differentiation with the medulla, normal thickness of the cortex, normal kidney size. So moving on from there, your next step would be to do a vascular exam, and a pre-renal AKI is going to be characterized by a decreased vascular exam, and that you'll see things like low IVC collapsibility, low IJ collapse point, collapsible ventricles, and atria. And just as a note, volume status can be difficult in certain populations, like those with extravasation of fluid from hypoalbuminemic states, like advanced malignancies, liver disease, and can also be limited in patients with large body habitus. So the value and extent of your evaluation will depend on your patient. Kind of a quick and easy evaluation that we do a lot is the evaluation of the IVC as a surrogate for volume status. In a very broad sense, you can divide patients into having a normal IVC, normal or to low central venous pressure. And those patients, you're going to expect to see a smaller IVC diameter, 2 centimeters or less, and you're going to see collapsibility of at least 50%. And for somebody who's really hypovolemic, you would expect to see even complete collapse of the IVC. On the other end of the spectrum, patients that have that are hypervolemic, you would expect to see a more generous IVC, greater than 2 centimeters diameter, and you would see collapse of less than 50% with inspiration. And in that scenario, that corresponds to a CVP of at least 10. Really, you just know that it's high. But it's really just kind of eyeballing the appearance of these things. These are kind of rough measurements. You can be a little bit more exact with it by calculating an IVC collapsibility index. So in this case, you use M mode to measure the amount that the IVC collapses. And the formula you use to calculate it is the IVC diameter in expiration minus the IVC diameter in inspiration when it collapses. Then you divide that by the diameter in expiration. And so that's expressed as a percentage of collapse. So the more the IVC is collapsing, the more you expect the patient will respond to a fluid challenge because you presume that they are intravascularly depleted. Not going to go into a lot of detail about this, but VEXUS, which is venous excess ultrasound grading system, is a tool that was developed to better characterize volume status than just looking at the IVC by itself. So it's really useful in situations where you might have a dilated IVC. So your initial evaluation, your quick and dirty evaluation might suggest that they have that their volume replete. But their IVC is really just dilated for other reasons, like if they have pulmonary hypertension, some vasculopathy, some other issues, but they actually are volume down. And so it gives you a better assessment of true organ congestion. So this, there's a whole grading system for it based on ultrasound findings, including measurement of your IVC, the hepatic vein, portal vein, and intrarenal venous Dopplers. And so this composite score, they've compared it to CVP measurement and IVC measurement by ultrasound, and it was superior for predicting risk of AKI and assessing volume status. So what you're looking for in the case of looking for organ congestion being hypervolemic, you'll see an expanded IVC, systolic reversal of the hepatic venous flow, severe portal flow pulsatility, and alteration of the intrarenal venous flow. And that all corresponds to venous congestion. So in the setting of somebody with a prerenal AKI, if you're doing this, then most likely your IVC appeared to be on the more generous side. So in that case, you would not see these other findings that suggest organ congestion if you had a prerenal AKI. So then moving on, we'll skip to postrenal AKI here first. So the traditional finding we think of with that would be hydronephrosis, so dilation of the collecting system of the urinary system. Just some important things to note, though. You always have to keep the context in mind when you're interpreting these images. Hydronephrosis can occur in situations where there's no pathology in the urinary system itself, such as in pregnancy or congenital nephrogenic diabetes insipidus. So context matters there. And a full evaluation in the case of a postrenal AKI would include imaging of the bladder in addition to the kidneys to help you determine the level of obstruction. And then it's important to know that you can also have a obstructive uropathy that does not have hydronephrosis. So any sort of condition that causes compression of Bowman space, which wouldn't allow urine to collect in the to go into the ureters and bladder and all that. That can happen. Malignancy, kidney stones in the right setting, and some post-surgical situations as well. So the lack of hydronephrosis does not definitively rule out the possibility of obstruction in the right clinical setting. And then just one particular obstructive setting to be aware of is papillary necrosis. This is a situation where you have necrosis of the renal papilla, and they actually slough off into the collecting system and cause obstruction, kind of a localized obstruction. The classic situation where you hear about this is in patients with sickle cell disease, and actually it's talked about even more in sickle cell trait, although in an absolute sense, diabetes is the most common setting that you'll see papillary necrosis. So to review some of these imaging findings that you'll see in the setting of a post-renal AKI, with hydronephrosis, we grade it based on the severity. It's grades 1 through 4, starting with grade 1, where you have just pelviectasis, which is just dilation of the renal pelvis. You'll see that kind of larger anechoic space in the center of the kidney. As you move up, you get more and more dilation. Grade 2, you get some caliectasis of the major calyces. Moving to grade 3, you get involvement of the minor calyces. You get kind of this more budding, broader appearance. And then moving to grade 4, you have further dilation with associated cortical thinning. And that's when you get your classic like bear paw sign, where the renal pelvis and the calyces look like a bear paw print. So the video here is just an example of a patient with probably grade 3 to 4 hydronephrosis. You definitely see dilation of the renal pelvis, and that extends out certainly to the major calyces, and maybe a little bit of involvement of the minor calyces a little further out with a little bit of cortical thinning. Towards the end there, as we fan through the kidney near the inferior pole, that large anechoic space is a simple cyst. So that's not part of the hydronephrosis. And if you're ever uncertain, you really want to see that your anechoic collection is communicating with the collecting system if you're not sure if you're seeing a cyst or hydronephrosis. And then this is showing an example of what you might see with papillary necrosis. So what you'll see is these, they can be hypoechoic, they might be isoechoic collections with some localized, surrounding anechoic space, and that's the local fluid obstruction at the level of the papilla. If this is a long-standing or kind of repeated insult with like multiple episodes of this necrosis, you can get calcification of these collections, and so you might see a hyperechoic rim with some shadowing in that case. In the pictures given here, you don't really see that. They're more isoechoic for the most part. So then our last category of AKIs would be intrinsic AKIs. In a broad sense, a lot of these are characterized by increased echogenicity of the kidney itself, but there are some nuances that you should be aware of to help you differentiate different causes. So ATN, acute tubular necrosis, relatively common cause of intrinsic AKI. So in this case, the hallmark feature is the impaired corticomedullary differentiation. So you're not going to really be able to see where the cortex ends and the medulla starts. Along with that, there's some more subtle findings. You'll have decreased mobility with respiration, some enlargement, and thickening of the capsule, although those things can be hard to see. What's important to note, and especially if you're doing an ultrasound on admission on a patient where you might expect or suspect that they have ATN, is that early on, the increased echogenicity will spare the medullary pyramids until the disease progresses and you get involvement of the more distal tubules. So in that situation, you'll actually get greater corticomedullary differentiation because you'll have increased echogenicity of the cortex and some of the more outer parts of the medulla, but the pyramids are still intact, and so they'll still be quite anechoic, and so you'll get increased differentiation early on. So it's important to, again, think about the context with your patient and where you're at in the disease process. And then, as I said, as the disease progresses, you'll get involvement of the pyramids, and there have been some studies for even monitoring kidney size during ATN to help kind of monitor progression of the process and to help determine prognosis. So having an increased diameter ratio is associated with having a worse prognosis. So that's potentially something you should make note of, is doing some actual measurements during your initial ultrasound exam. The next major category there would be AM. This one, really, the findings are quite nonspecific. So you have the increased echogenicity that is common among a lot of these intrinsic AKIs, but it's really difficult to diagnose by ultrasound findings alone, and a lot of these entities are ultimately going to need a biopsy to diagnose. A few special cases. So diabetic nephropathy has some more unique features. So it's important to note you can have periods of rapid progression of what is truly a chronic kidney disease that could meet criteria for AKI. So in that situation, the findings would be you'll see this increased echogenicity, which you can see in other types of AKI, or you could potentially see in CKD. How this is going to differ potentially from other causes of CKD is you actually have kidney enlargement in the earlier phases of diabetic nephropathy. That's associated with even an increase in GFR initially, along with microalbuminuria. And it's really only as the disease becomes a lot more advanced and you get a lot more sclerosis that you actually start to have a decrease in the kidney size. So kidney size might be misleading. A patient that has CKD with diabetic nephropathy might have normal or even somewhat enlarged kidneys. So that's something to keep in mind when you're doing your ultrasound. And then a last category here would be different types of infiltrative disease that can cause intrinsic AKIs. So starting from the top, multiple myeloma. This one, again, pretty non-specific findings. You'll see increased echogenicity of the kidney, but the kidney size is normal. And there's, if you're doing a vascular assessment of the kidney, there's no change in the resistive index. This is important because really the findings can be similar to other types of AKI, but these would be persistent findings. This would be a chronic finding of increased echogenicity without a change in kidney size. So kind of some features of a typical AKI and typical CKD. With lymphoma, which is pictured on the upper right, you get these areas of hypoechoic spaces, and there's not much internal vascularity with those. And it's hard, again, here we just have a single still image that shows, and these arrows are pointing to a few hypoechoic areas in the kidneys. It's hard, especially for these upper ones, seeing a single still image to tell, am I just seeing part of the pyramid, or is this something pathologic? But you might see, abnormally large hypoechoic spaces, or involvement down into the renal pelvis, or even into the perinephric fat. You'll see some of these hypoechoic regions also, so that can give you some clue that there's something else going on there. And depending on the extent of infiltration of the lymphoma, then you might have increased size of the kidneys as well. And then the last one here is amyloid. So the picture we have there is the bottom right. In this case, again, increased cortical echogenicity. The somewhat distinguishing feature for this one is that you have really prominent appearance of the renal pyramids. And you can kind of see that in the picture here, compared to some of the other ones we've looked at that had increased echogenicity. You get this really sharp and significant contrast between the degree of echogenicity of the pyramids and the surrounding medulla and cortex. In some cases, this can look similar to the appearance for multiple myeloma. And of course, your lab evaluation for amyloid would show albuminuria, potentially nephrotic syndrome, rather than a paraproteinuria. And like diabetic nephropathy, amyloid kidney, especially early on, classically shows enlargement of the kidneys. And it's only with fairly advanced disease with significant loss of renal function that you'll see smaller kidneys that you might expect from other causes of CKD. So last main slide here is a algorithm that kind of tells you where to go with your initial ultrasound findings. So you do your kidney ultrasound findings, and then really based off of the echogenicity of the kidney, that's your first branching point here to help you figure out what might be going on or what steps you should take next. So with increased echogenicity, again, you can see that in CKD, you can see that in ATN and sometimes AIN, and then you can see that in infiltrative diseases. So depending on the context of your patient's AKI, that would help guide further evaluation. For a patient with an AKI with normal echogenicity, then you're thinking this is potentially a pre-renal etiology. That would prompt you to do your cardiac and vascular exam. And if that's consistent with intravascular depletion, then you could challenge your patient with fluids. If your kind of quick and dirty IVC evaluation wasn't large, but you think that there might still be a pre-renal situation, that's when you might pull in a more comprehensive evaluation with Bexis and at least evaluation of the JVP to help evaluate for potential cardiorenal or hepatorenal syndromes. And then this last major branch here, the hypoechoic, can happen with cortical necrosis or the papillary necrosis like we had discussed, and can also happen with hemorrhage. And then the one all the way over here with hydronephrosis or obstruction, and as we said there can be some other causes of obstruction as well where you might not see typical hydronephrosis, but that can help guide further evaluation, looking at the bladder, full urinary system, and determine your level of obstruction. So conclusions for this, again, AKI, it's a really common comorbid condition in hospitalized adults. It is associated with increased mortality. And so it's important that we diagnose AKI and try to, as quickly as possible, determine the etiology so we can potentially reverse it and prevent complications. POCUS is a useful tool that can be used to help guide that initial management. Your full evaluation will include, of course, your examination of the kidneys, but then generally some follow-up imaging either of the full urinary system or the vascular system to follow up your initial findings. And it's always important to keep in mind that a lot of the sonographic features of AKI are pretty non-specific. So POCUS can help narrow down your differential and guide further evaluation and possibly just your initial management. But more testing is usually needed, and you won't necessarily get to a definitive diagnosis with POCUS alone. All right. So these are some of our sources. Thank you guys for listening to our presentation.